Live from Boston, my name is Emilio Madrigal, and welcome to this edition of Pathcast. Today, we welcome back once again Dr. Fausto Rodriguez from Johns Hopkins University. Believe it or not, today is lecture number 9 in this. I guess it's becoming a mini neuropath fellowship, and the title of this lecture is "Germ Cell Tumors of the CNS." As always, please post your comments and questions in the Facebook and YouTube watch windows, and we'll make sure to pass those along to Dr. Rodriguez at the end of the lecture. I'm also joined by my colleague Rifat Manan, who's at the University of Pennsylvania in Philadelphia. So without further ado, we'll pass the microphone over to Dr. Rodriguez.
All right. Well, it's a pleasure again to be with you this month, talking on another topic of surgical neuropathology. This will be germ cell tumors. Just to get started, germ cell tumors, the morphologies are similar to the ones that you see in other places. So there's a lot of overlap with the germ cell tumors that you may see in other body sites. But are going to be probably focusing on some topics. The anatomy is something critical, and of course this they engender several differential diagnoses that we're going to also cover briefly. So let's get started. Just a little bit of introduction. In the CNS, germ cell tumors have a predilection for midline locations, and there are two sites in particular where they like to occur, which are the pituitary and the pineal in the pineal region. So it's important to have that in your differential diagnosis. Oftentimes, biopsies from these sites are small, and crushed. So there's something you really have to have it in mind, particularly in young patients, the possibility of germ cell neoplasia when you see biopsies from these sites in frozen section or in permanent sections. They tend to occur mostly in children and young adults, and they have a lot of similarities. Sometimes we have slightly different names for the same morphologic pattern. Optimal management of these neoplasms is multidisciplinary because you do have different markers. Oftentimes you don't sample the whole tumor. You can have different type of patterns occurring co-occurring in the same time. So they are very sensitive to radiation. Some of them, particularly germinoma. So there's a very importantly to have in mind the multidisciplinary approach to the treatment of these tumors. This is a summary of what you have in the WHO classification, how they are in 2016, all the different patterns. Germinoma is a slightly different term in the CNS. It refers to, it's equivalent to seminoma in the testicle, and this germinoma in the ovary. So the morphology is very similar. And then you have the other patterns that you're used to seeing in other sites. So you oftentimes, germinoma is probably the most common morphology that we see, but we also have mixed germ cell tumors with a variety of other components on occasion. Okay, let's start with case number 1, which is a 24-year-old woman with several year history of vague visual complaints, but more recently developed increased headaches, thirst, and polyuria. Hopefully you had a chance to review some of these. They are on the web, and you can also review them after. But this is case number 1. Very fragmented. So you can see two tumor samples from this place. This is actually a generous biopsy, to believe it or not, compared to some of the biopsies that we get on occasion for germ cell tumors in the CNS. So it's something you have to get used to. They're fragmented. You can have blood clot and other things, but you do have diagnostic tissue here. And this is a pattern that is, of course, very common in surgical pathology in general. You have these large cells. And something that is very distinctive is that the nucleoli have geometric shapes, bar-shaped or square-shaped. That is highly typical of these. And also you have a variable interspersed lymphocytic infiltrate. with germ cell tumors, again, it's important to look at all areas and on all slides because you can have different components. And when you have various components, it's important to document more or less the relative proportion of them. That I think makes the report useful. But I think that it looks like these, you have a uniform proliferation of same cell type. I believe I have some immunostains as well to share with you. This is some of the routine immunostains that we do. This is OC34, and you can see strongly positive in those large cells. So essentially, you have the diagnosis by now. This is a germinoma, probably the most common germ cell tumor that we see in the CNS. Very frequently, it occurs in pure form mostly. Can occur with other components, but for the most part, it tends to be pure. And this is KIT. As you know, KIT gives you this strong membranous staining. And germinomas is not the most specific stain, but it's relatively sensitive. Most of them have it, and it's usually like this, uniform, strong membranous. So this combination of findings, the morphology, and everything else really allow you to arrive at the diagnosis. These stains are more important not when you have the classic morphology of germinoma, but sometimes you have these very tiny biopsies and maybe rare cells here and there. So you have to really make sure to use the stains when you have a biopsy, particularly if this may be obscure, the true nature may be obscured by inflammation, for example. In those cases, the immunostains can be very helpful. This was the preoperative imaging, and you can see this is an area where it happens. You oftentimes have findings like this in which you have contrast-enhancing lesions that are located thicken the pituitary stalk, hypothalamus, sometimes may even extend into the third ventricle or into the follow the optic pathways is something that we have seen as well. So in these instances, and you can see the biopsy is not always, most of the time it's not representative of the whole lesion, may not be because you have oftentimes larger lesion and only a small portion is sampled. So the diagnosis here was a germinoma. Again, this is analogous to seminoma in the testicle and this germinoma in the ovary. And this is a smear just to show you what it looks like. They are very easy to pick up and smear. So particularly when you have small biopsies like this, smears become essential in your frozen section interpretation. And only with this smear, you can probably really strongly suggest, if not make the diagnosis outright. You have these large cells, again, kind of bar shape or squared nucleus, and a sprinkling of lymphocytes in the background. Okay, let's move to case number 2. This is a 7-year-old girl with an heterogeneously enhancing supracellular mass. This is case number 2. Okay, several fragments here and there. This was actually a very challenging case. we are seeing some multinucleated giant cells. Again, something that you have happens with these biopsies, you can get quite a bit of a crush artifact. So we feel that this is the dominant component here. These large multinucleated cells. You can argue there may be some inflammation, some mononuclear cells as well. It's important in these cases to really move around and look at everything. Here is an area where you're seeing some more mononuclear cells with some atypia. More of these multinucleated cells. You do have a fibroblastic response, it looks like. Okay, so the most striking component are these multinucleated giant cells. And then we want to know what they are. So we did a few stains. This is cytokeratin CAM 5.2, which is actually strong in those cells. Not only in those cells, but also it's highlighting also, it looks like a mononuclear infiltrate. This is OC34. Again, a very useful stain for the recognition of predominantly germinoma. And you can see here there's very little of it. You have this blush, but it's not the strong reaction that you see in your typical germinoma. So in some ways, that moves us away a little bit from it. And this is beta HCG, which oftentimes gives you this background, but you can argue that many of these cells are also positive for it. A lot of beta HCG. SAL4, some positivity. It's less specific in our experience than OC34. And CD30, of course, to look for embryonal carcinoma. So this one we interpreted as non-germinomatous germ cell tumor. Basically, it's not germinoma. We could not document a good germinoma component with syncytial trophoblast. And actually, the findings we felt that they were most suggestive of choriocarcinoma. Rare in the CNS, but it certainly can occur in pure form. So we were limited by the relative lack of cytotrophoblasts and the crushing artifacts, but this was actually what we were favoring and that we convey in our report. It must be noted that syncytial trophoblast can happen in germinoma, right? And it can be even associated with beta HCG, and it's not really, does not affect prognosis in the context where you're convinced that it is developing in a germinoma, in a pure germinoma. All right, moving to case 3, 23-year-old male with a right infrafrontal mass being, I think, in the infrasurface of the frontal lobe. All right. This is a slightly more heterogeneous biopsy. You can see something that is evident. You have some of these fat and mesenchymal component as well, in addition to fat, some nests. And actually you start seeing here some possible hair. Few almost adnexal structures. More of this fat. Some histiocytes, calcifications. So the diagnosis here was mature teratoma, which they occur also in the CNS. So among the germ cell tumors that have the best prognosis, you have germinomas and mature teratomas. Those are the good players really in the CNS. There's some overlap with dermoid cysts, which you can also see in the CNS, and that mature teratomas, we apply that to lesions that are more solid and more complex. Sometimes you have these pure cysts that have mostly look like an epidermoid cyst with some annexal structures, and we reserve the dermoid designation to those with the understanding that some of those are probably developmental and may occur also in the midline in relation to areas of closure or during development. Next is case number 4. 49-year-old woman had headaches for a few months, and they identified this 1.4 centimeter cystic abnormality in the right cerebellar tonsil. This is a CT scan which was done. A little bit difficult to see, but it looks like there's a lesion there in the cerebellum. Okay, and here is case number 4. All right, so this is what you have. Also a very heterogeneous lesion. And this is interesting because you have some epithelium, that columnar epithelium with some goblet cells. You have smooth muscle. You have this epithelium here, these papillary formations that when I saw it for the first time, I was even concerned, are we dealing with some sort of choroid plexus tumor? You have almost colloid-like material in some of these. Some almost an invagination of the epithelium. Smooth muscle, probably. Histiocytes here and there. Okay, and I have some stains on this case as well. This is the CAM 5.2, so a lot of that epithelium, not surprisingly, expresses keratins. You can see a nice cystic lining. Complex papilla. This is smooth muscle actin. Again, a lot of that stroma is actually smooth muscle, so it's not a desmoplastic response to a choroid plexus tumor, for example, which was in the differential diagnosis. You do have definite smooth muscle formation. And interestingly, you also have TTF1. So we're wondering if you did what type of epithelium is happening there. The patient was, of course, explored for the possibility of carcinoma, but you do have here actually TTF1 in some color formation. We speculated maybe this is, thyroid metaplasia or some sort of thyroid epithelium or even pulmonary epithelium. That's the differential diagnosis really in this case. But this was a case that required quite a bit of thought and the exclusion, of course, clinically of metastasis from another place. At the end, we put it in the category of mature teratoma with, again, a lot of caveats and a lot of discussion with the clinical team. So it's a teratoma curious with a bit more heterogeneous type of pattern. So they occur in the CNS, and they don't only necessarily occur in the pineal region or the suprasellar region. I wanted to show this case also because it's one arising actually in the cerebellum. So you can have germ cell tumors occurring on other sites in addition to the classic suprasellar and pineal region locations. Okay, moving to the next case, 24-year-old woman, again with a suprasellar mass. Okay, and we are seeing a pattern very similar to what we saw in the first one in areas. Clear cells, a sprinkling of lymphocytes and even plasma cells. Well, we also have a suggestion here. You can argue that there is an area of germinoma, but then you start seeing an area where the cells become a bit more pleomorphic, a bit more different cytoplasmic quality and nuclear quality, brisk mitotic activity. Here you see it as well. So we feel that this is a bit more heterogeneous than just a pure germinoma. That was our thoughts at the time. And it's particularly highlighted here at the edge. There were also areas of necrosis. A lot of inflammation. So again, a lot of these. So these, of course, require a lot of immunohistochemical characterization. I don't have all the original immunostains, but I can we can at least see some of these. We have another piece. Let's take a look at the other piece as well. Very similar hemorrhage. Here, a bit of a more complex morphology. So we felt that there is more than just a pure germinoma here. So this one, actually we interpret as a mixed germ cell tumor. We felt that there were some germinoma and embryonal carcinoma components. I don't have all the slides, but you had a component that was CD30 positive and distinct from the germinoma. So this is something to have in mind. Most of the time, as I mentioned, we tend to see germinoma as a pure pattern, but you do have this mixture of components, which can be very challenging to assess, given the small nature of many of these biopsies. But this one, we were convinced, mostly at the immunophenotypic level, that there was an embryonal carcinoma component. All right, case number 6. Now we have a 1-year-old girl with a mass in the 4th ventricle. Just now going away from the classic sites. And right off from low power, you can tell that there is quite a bit of an heterogeneous appearance to these tumors, something that you may have encountered in other organ sites. You have here some CNS type parenchyma. You have some complex epithelium. Maybe some here, some epithelium maybe endodermally derived with goblet cells, well-formed cartilage, bone formation. Neural tube type of epithelium, something that you are probably used to seeing if you see gynecologic samples. Pigmented epithelium. So this is one that seems to have pretty much everything that you can have. Very lobular. A lot of these epithelium, neural tube type of epithelium. Here, of course, the most important differential diagnosis is having an embryonal neoplasm. So you can have a lot of heterologous elements in embryonal tumors, including medulloblastoma. So it's something really to have in mind that that's the main differential diagnosis, particularly a young patient with a posterior fossa mass. More of this neural type of epithelium. And you see what makes it a neural tube is you have this pseudostratification and almost like a 2 different basal membranes, one at the luminal surface and one at the bottom. You even have some choroid plexus type of epithelium, which is I'm also used to seeing this in some of the gynecologic ovarian immature teratomas. So pretty much everything here is being developed. And the diagnosis here is a pure immature teratoma. Again, the main, particularly in these young patients, the main goal is to exclude the possibility of some sort of embryonal neoplasm with some heterologous elements. So that is something to have in mind. Moving to next case. This was a 6-year-old, again, with a suprasellar mass. I think we have many of these have been in the suprasellar region. So another very heterogeneous tumor. Has some components that are very similar to the first case, right? So you have cartilage, you have epithelium, stroma, cysts, glycogenolytic epithelium, maybe a cystic formation. So something that was a bit different here, and this again highlights the need to look at all the components in other areas, is this here. This looks a bit more of a solid component. So here your options is you may have another germ cell component and you have to probably characterize it. And you can have also malignant transformation in a teratoma. You can have a variety of somatic type malignancies developing. So those are the things that you have to look, because they, of course, increase, can affect the prognosis of the patient. So if you look here, this tumor is a bit pleomorphic. Again, difficult to ascribe to any specific category of germ cell component. Something that was catching my attention was you have some hyaline globules. Let's look at it more carefully in other areas. Very solid proliferation. It's certainly not a germinoma. You can see it here. A lot of single cell necrosis. Again, quite a bit of pleomorphism in areas. And we have some stains. This is cytokeratin CAM 5.2, which is strong in many of the components. You do have the solid components and also some of the glandular components having this strong cytokeratin positivity. SAL4 is a nuclear stain. You see a lot of these SAL4. But what really helped us here was alpha fetoprotein. So that component has a lot of alpha fetoprotein expression. And glypican-3 is positive. So the co-expression of those two markers in this context supports a diagnosis of at least in part a Yolk-Sac component. In this particular case, there was a lot of pleomorphism, which actually has been described before in the urologic literature in testicular Yolk-Sac tumors. So that can be a little difficult to, that can be a little confusing because this one has a more solid pattern and also has that that pleomorphism. So mixed non-germinomatous germ cell tumor with immature teratoma, we evaluated, again, we have other slides, but we assess it as having been about 70% immature teratoma and 30% yolk sac. Okay, the next case is a patient, is a 4-month-old infant with increasing head circumference. And this is what we have. We have a plain almost CT bone with bone windows, actually showing a suprasellar mass with this very peculiar type of calcifications, almost following around the circumference of it, and something very similar in MRI. Very peculiar. Really have this in mind. These peculiar calcifications in a suprasellar mass. And of course, probably this is something you picked up on the H&E. You have teeth actually, and that corresponds to those calcifications that we're seeing on the MRI. And when we look around, we also have epithelium. What about the distinctive type? This is more adamantinomatous epithelium. You also have a suggestion of ghost cells or wet keratin, reticular stroma, palisading. Of course, we spent quite a bit of time looking at all pieces to make sure that this, if there were more other components that could affect the differential diagnosis in this case. But it was all that. Again, wet keratin in the center of some of these nests. So here the diagnosis was actually adamantinomatous craniopharyngioma, and this is a differential diagnosis, and it was a differential diagnosis at the time of frozen section as well, because you can have teeth formation with this. So that is something to have in mind. So you can have teeth formation, of course, it's a hallmark of many of the mature teratomas that you see, particularly in the ovary. They can happen intracranially, but this is one differential diagnosis, same location, and that's what we spend quite a bit of time trying to make sure that we don't have other germ cell components in this very unique case. So rarely you can have craniophryngiomas that have adamantinomatous that has overt tooth formation. So what is the differential diagnosis of germ cell tumors? I wanted to put that last case to start this topic. And you have a variety, right? We were talking in germinoma, you have to think about lymphoma, other things. Immunohistochemistry helps you a lot. Well, there's a variety of lesions that can also give you this heterogeneity that you can see with germ cell tumors. One particular tumor type that is in the differential here, and I have shared with you a case of these when we were talking about our pineal region lecture, is this pineal enlarged tumor, which has a lot of components, just like germ cells tumors does. But you see here, you have pigmented epithelium, and a primitive component. In the WHO, this is felt to be more of a variation of pineoblastoma because, and I see provisionally has been associated with it, given that you do have an embryonal component But this is a really unique tumor type in a sense of the various morphologies that you tend to see. And this occurs in the pineal region, again, where germ cells tumor occurs. So it's something to have in mind when considering the differential diagnosis of pineal region tumors. Now, there is another lesion that we are occasionally seeing in the modern era or more contemporary area of that raises the possibility of germ cell tumor. This was a relatively older patient that actually presented with some polyneuropathies, and this is the PET scan here. You can see a lot of uptake in the lower spinal region, and the biopsies actually showed a lot of CNS type of tissue engulfing peripheral nerve fascicles. So this was a very mature lesion with associated also inflammation of the peripheral nerve fascicles. So this was a remarkable case, and there's been several institutions that have been starting to see this. And this is something actually that you didn't see historically, but it's something that has been referred in many different terms as stem cell tourism, which happens now with these injections. There are patients that go into these clinics, which are not really, it happens usually outside of the US. Some of them are very desperate to look for regeneration after spinal cord injury. Others, like we have seen patients that do it just to rejuvenate themselves. They feel that they're getting old and they want to, get the energy that they had years before. And we have these ones, what you tend to see, you have these glioneuronal lesions. They are very mature lesions that have a variety of either glial, occasionally they can be very hypercellular and they can be confused for a glial cell tumor, but the history here is key. And the idea is you can get these lesions that simulate germ cell tumors. For example, this is very analogous to what you get in mice, for example, in experimental models in which you inject IP cells and you get these mature teratomas almost looking type of thing. So this is something to have in mind. Here the history is really very key. What do we know about the molecular pathology of germ cell tumors? About 50% of those have somatic mutations in KIT, RAS, or AKT/mTOR pathways. KIT is not only overexpressed in CNS germinomes. For a long time, we used it as a diagnostic marker because it's clean, but it's actually mutations in KIT are actually common in germinomas in particular, and the ones that don't have it tend to have alterations in KRAS or NRAS. There's a lot of efforts now to apply genome-wide testing to many different tumor types, and that has also been applied to CNS germ cell tumors. They tend to have global hypomethylation, and it's interesting that different components of mixed germ cell tumors may share identical mutations, suggesting that they have a common precursor, but they can have a distinct methylation profiles, telling you that there are some differences as well. All right, so let's move to some of the multiple choice questions. I think we have some time still. So there's this 25-year-old woman that presented with polyuria and polydipsia. Again, this is related to diabetes insipidus that you can get as many hypothalamic masses. They discovered an enhancing hypothalamic mass, and which was biopsy, and histologic sections demonstrated numerous small T cells and granulomas. The mass continued to grow despite immunosuppressive therapy. One likely diagnosis is, I'll give you some time to think about it.
I think we are getting a lot of B's here. B as in boy. That's germinoma.
All right, and actually that is correct. So it's something to, this is, we didn't go too much into detail here. I show you some more classic cases for at least for germinoma, but I tell you, this is a problem when you have very tiny biopsies, and some of these patients may actually have repeat biopsies. I have seen biopsies from patients that eventually are found to have germinoma that had been called, hypophysitis, because you have a biopsy from that region, has inflammation, and a diagnosis of hypophysitis is made. The patient, of course, doesn't respond well to that type of treatment, and repeat biopsy can show the germinoma. So this is something that is essentially part of classic pathology teaching, that germinoma can have granulomas, can have a lot of inflammation, and this is particularly problematic in the CNS because, again, you have very tiny biopsies. The hypothalamus and the pituitary stalk, there's always an effort to try to preserve function as much as possible there. So you may get very little material. Something to have in mind that this can be the case. I never make the diagnosis of hypophysitis, without inflammation in the pineal and the pituitary gland, because and that's a big mistake sometimes that I see happen. They have this in the differential diagnosis, but if you have inflammation on the hypothalamus, a mass, you really have to think about germinoma. Next question: mutations in which of the following genes is typical of germinoma?
I can see choice C by someone, that is for KIT. Let us see if we got more coming. I think E is also there. So someone says it is SMARCB1. That's the option in E.
Actually, the response is KIT. So KIT is very typical of germinoma. As we discussed, slightly over half of germinomas have KIT mutations or mutations in other RAS pathway components. SMARCB1 is, you have to be careful. This is actually loss of SMARCB1 is typical of atypical teratoid rhabdoid tumors, which can also occur in the pituitary. It has a predilection sometimes for in the adult population for the pituitary region. So something is in the differential diagnosis of germinoma, and loss of it is really how you recognize it. A 28-year-old man presented with severe headaches, and a pineal region mass was biopsied. Histologic sections demonstrated syncytial trophoblast type multinucleated giant cells. Mononuclear cells containing large nuclei with bar-shaped nucleoli. What is the most likely diagnosis?
So a lot of people are saying it's choriocarcinoma.
Okay, and certainly it could be. In the case that I showed you, we were favoring more choriocarcinoma, but really when we see this more often, we tend to see actually this syncytial trophoblast in association with germinoma. So you can have a sprinkling of syncytial trophoblast in germinoma. I try to say bar-shaped nucleoli. These are actually, this is typical, the cytology of germinoma. So you have to pay attention to the mononuclear cells. If they tend to have the classic features of germinoma, most likely you're dealing with a germinoma with syncytial trophoblast, which again can be associated with beta HCG elevations. That is certainly possible, and still you don't have the bad prognosis that is associated with primary choriocarcinoma intracranially. Here, this is a little bit of a tricky case because choriocarcinoma is certainly the main consideration that you're worried about, but germinoma being more common by far as a primary tumor in the CNS, you do tend to see these syncytial trophoblasts on occasion, something to really have in mind. Okay, and this is question number 4, is a final question. Which of the following germ cell patterns is associated with a best prognosis in a primary germ cell tumor of the central nervous system?
Yeah, we are hearing teratoma. That's option D. There is
That's
more
correct.
of teratoma.
Yeah, so mature teratoma. Mature teratoma, of course, can be very aggressive, but mature teratoma and germinomas, those are the two patterns that have the best prognosis in the CNS. So it's something important, in particular in pure form. Again, many of these germ tumors can have a variety of components. Oftentimes you may have very tiny biopsies, but you more or less, you only can go what you see. So you have to really try to focus on the patterns that you see and try to be as precise as possible and document it, their relative abundance if possible. Okay, so this concludes today's session. We have 2 more sessions to finish this complete series. I won't go completely away, so I really enjoying sharing many of these cases with you. So, but at least I wanted to do a systematic coverage of different areas of CNS surgicals that you can see in practice, and that I tend to see in my traditional practice and also in my consultations. So the next topic, I promise I'm going to have a very nice set of cases. The peripheral nerve is a topic that is especially close to my heart. And then we'll finalize in January. We'll take a break in December, but in January we'll finalize with some more secondary malignancies plus hematolymphoids that you can see in the CNS. Again, as I just want to re-emphasize this, that all these lectures are being put together in a collection, that playlist that you can go back to. If you have questions, clarifications, please feel free to reach out to me at any point. So I do truly enjoy and hope that this can be of help to you in your practice and your professional growth.
There is one question, Dr. Rodriguez, from Anna, who is from Argentina. So she also said that it's a pleasure for her to listen to you. So her question is, what about the prognosis of immature teratoma?
Immature teratoma, yes. Many of these germ cell tumors in general, they are better than other alternatives. They have good therapies for them. So immature teratoma has a worse prognosis. In general, like in many different places in the CNS, in the body, you want to separate germinomatous for non-germinomatous germ cell tumors, right? So if you have a pure germinoma, that has a very good prognosis, and they many times, if they get good markers, they may even treat them and they can go away just by radiation. So they're very sensitive to radiation. They have a very good prognosis. And the second pattern is mature teratoma. Anything other than that tends to be associated with a worse prognosis and less responsiveness to therapy. So immature teratoma, in this context, is associated with a worse prognosis. It's better than some membranal tumors, than a high-grade glioma, for example, but they tend to have a worse prognosis than pure germinoma or pure mature teratoma.
There's another question from Prasad, who is in India. So he wants to know about useful immunomarkers in differentiating germ cell tumors of CNS.
Correct. So I went through some of them in here, but OCT3/4 is one of the best ones to recognize germinoma. It's relatively sensitive and specific. I use KIT also for germinoma. We use it in the CNS. It's not specific. You know that there's a wide differential of tumors that can have KITs, but as I mentioned, KIT is actually, they have mutations of it. So it's very relevant to germinomas and very strong for it. CD34 allows you to recognize embryonal carcinoma, and AFP and Glypican-3 are useful for York-Sac. Beta HCG, you can do it for the syncytial trophoblast and for choriocarcinoma, although it tends to have quite a bit of background in our experience.
So that's all we have now. And as Dr. Rodriguez mentioned, so please feel free to post your questions either on Twitter or on Facebook. So he would be more than happy to answer them. And Dr. Rodriguez will be available. And he would be back on November 26th, as he mentioned. And he is going to discuss on peripheral nervous system tumors. So stay tuned. And thanks, viewers, for joining in. Dr. Rodriguez would be happy to hear that we had viewers from so many different continents. So we had viewers from Asia, including Iraq, Iran, Philippines, Taiwan, and then we had someone from Georgia joining in, also from Guatemala, and of course from North America, we had viewers from Montreal, a resident from Montreal, and also a lot of people from US. So thanks everyone for joining in, and thank you, Dr. Rodriguez.
Okay, my pleasure. See you next month then.